Thank you so much. It's a great honor to be here today, and I'm delighted to be here to answer this difficult question. I mean, plans are very important, but there's many plans around Europe to tackle cancer. The question is how one implements different plans. And this is a key question. How can we facilitate this? The European Union has developed many different plans over the last 15 years. There's a string of plans. We had the European Partnership for Action Against Cancer. You had CanCon 1, you had CanCon 2. And there's many revisions of different legislative frameworks. You had a clinical trials regulation that was revised at the European level, but this has dramatically reduced the number of academic clinical trials taking place in Europe. You had a general data protection regulation that was revised, and this has had a dramatic impact in terms of how we share data, or how data is utilized. You had the in vitro diagnostics regulation that was revised, and this has dramatically impacted lab-developed tests. So there's many different issues in terms of what is the regulation and what is the policy or what is the politics around how we can bring innovative healthcare into healthcare systems. And a lot of discussions was answered in the last presentation by all the great speakers. But the issue around, I mean, personalized medicine is really around how do we diagnose patients earlier, and how do we treat patients earlier to improve their quality of life. It's not really per se about expensive therapies, which is part of the story because there is therapies that are developed to target certain diseases. But the question is, we have better understanding of diseases now, and the question is, how do we apply the science that is developed so it can be brought into healthcare systems? The oncologist mentioned that science is moving quite fast, which it is. But we had a big congress in Madrid just 3 weeks ago, where great science was presented. But a lot of this great science will take 10 years to get into healthcare systems. A lot of therapies or diagnostics that are available in the US will not reach Europe, or different therapies that are available in different countries in Europe are not available in Greece, which is shocking. So these are big questions that plans are put in place, but the question is how we implement plans. A lot of politicians do talk then about, well, we have to find the money, which was mentioned as well. But there is the money there. I mean, we find money for Ukraine, we find money for different issues, but a lot of budget is spent in the wrong places. The question is how do we reallocate resources that has been allocated for an area that's not bringing the same return on investment. And this is a key problem. We spend 10% of the healthcare budgets are spent on therapies, only 2% is spent on diagnostics. And we had and the healthcare systems are set up to treat patients, not set up to diagnose patients. And often the payers and the insurers are very much focused on this aspect of treating patients rather than saying, how do we diagnose patients? So the European Union, one of the areas that we worked on at the European Union back in 2015, when I had less grey hairs, was on these council conclusions on personalised medicine. And in a sense, they were a conclusion, but we tried to make them to be an introduction as well at the same time. And here is what the member states agreed at the European level to a definition of what is personalised medicine. And it's really focused on, I mean, utilizing medical modeling, characteristics, also all these nice fancy words that a lot of scientists will understand. But the question is, how do we diagnose patients earlier so that we can treat them? Earlier was mentioned as well that we want to put the patients at the center, and this is a patients meeting, which of course is important, but in reality as well we want to put healthcare systems at the center. How can we bring the different actors in the healthcare systems together to work together in a more structured manner? So you need the patients, which are of course at the center, but you need also the clinicians that we just heard from. You need the payers, the insurers, you need the regulators and policymakers, but also you need industry from the diagnostic side, the pharmaceutical side, and the IT side, and they're often left out of the discussion. So we have three different steps, one could say, how you could bring personalized medicine into the area. and they all look pretty simple. So you have great science that is developed between different interdisciplinary practices. This is developed in the private sector, or often in the public sector, and the private sector helped to distribute it across different healthcare systems. Then you have the whole issue around how this is translated into different healthcare systems. So you need different types of medical professionals in the area. Then the question is, what is the design of innovative processes? So how do we understand prevention? Is prevention also, more broadly, early diagnosis so that we can avoid late-stage diseases? Most of an expenditure of a citizen, of a European citizen, is spent on the last 6 months of the person's life. So how could that expenditure be distributed across the whole lifespan? So this is just a question of what is the innovative models that we can support that, and then how do we reorganize healthcare systems? So a big issue around the area is healthcare workforce. This is if I was focusing on a plan or an action plan, what are the needs in the healthcare system that we now need to bring innovative approaches into the healthcare system in a more structured manner? And there's a big shortage of pathologists in all countries. So what is the need to best tackle that? Or if we say we want molecular tumor boards, how do we work between different healthcare systems to facilitate this? So these are basic questions. A lot of the regulations as well that are developed at the European level, maybe they're not helping. I mean, some of them are helping, but the clinical trials regulation, clearly, it was implemented in a way that academic clinical trials has gone down dramatically in Europe, and investment is switching over to Europe and other regions. So this is a big issue. Then there's a lack of coordination in terms of the general data protection regulation at the European level. Consent is understood different ways in different countries, and then you have different people want to worry about how their data will be shared or utilized, which we have a lot of legislation in place. We have discrimination legislation in place, so if somebody discriminates against a person, this legislation can be utilized. Or if somebody steals data, then the criminal legislation can be utilized. Not to create new architectures, which is creating this problem. So a lot of countries have gone down this road of making more difficulties on behalf of patients, which has caused a lot of problems. Then you have a huge disconnect between the clinical guidelines that come out from each country. Clinical guidelines that come out from the medical societies. So these clinical guidelines come out, they recommend a liquid biopsy or NGS or certain treatments. But then the policy guidelines was mentioned earlier. There's a disconnect between the funding that's available at the country level and to support the implementation of the clinical guidelines. So this is a big issue. And then you have different healthcare systems organized in different regions. So you have to take account of what is the resources in each island, say in Greece, which island, and then how do you have more of a framework to do that? And then how do you implement this in a more structured manner? So no country is doing very good, one could say. I mean, if I just look, I will focus primarily on this presentation around diagnostics, so molecular diagnostics, screening, early diagnosis, and also therapies. But you can see here for lung cancer, for example, for EGFR testing, for ALK, ROS1, BRAF, PD-L1, different countries have different ways to reimburse this. Some are fully reimbursed, some is only the public healthcare systems, some are partly reimbursed. So depending on which biomarker you have, which will determine if you have a better quality of life, this is hit and miss on which way that we can have this. And Europe should really, talking about an innovation fund, Europe should really structure this in a more concrete way, saying if it's only 2% of the healthcare budgets, how could this be done in a more effective manner so that we could really diagnose patients earlier? Maybe we cannot treat all patients, but it's best to know if the disease exists. Then we can allocate more and more investment to this, and public and private sector can work together to structure this. The same with the novel drugs. You have different drugs when they're approved by the EMA, they're registered, but then this treatment are reimbursed or not reimbursed, or available, not available, or there's big delays or differences in each country. Certain drugs may be available in Greece, but not in Bulgaria, for example, or vice versa. So this is a big shame. So my colleague prepared some nice slides for me, so which I'll try to go through very quickly based on some of our publications. So there's quite a lot, just to let you know. But we have demand-side issues and supply-side issues in terms of how we can implement, say, personalized medicine. So demand-side issues would be the awareness in the healthcare systems of how we can implement this in a more effective way. What's the educational and training needs to do this? And what is the clinical and research standardization and systems in place? The supply-side issues would be, say, at the governmental level, what are the governance frameworks that are there? What is the testing infrastructure? And are these reimbursed? But the problem with reimbursement is one of the core issues because different countries have different decisions on this. Although we have a health technology assessment procedure, now we have a regulation on that, only the clinical aspects is going to be more unified. I do it in inverted commas, but then not the reimbursement aspects. So there's no, and this is important because the evidential needs in different countries differ. So how long is a piece of string is a good question, because then it confuses the issue of whether a patient has a right to expect a certain treatment or a right to expect a certain diagnostics, which really determines if they live or die or improve their quality of life. And this is a huge issue. So then the Commission have come up with, they love big titles. I guess they were watching Mission Impossible, and then they felt more ambitious to be Mission Possible. Maybe they got re-elected at the time, but which they did actually. So they came up with Conquering Cancer. Can we have a mission-based approach? So they have 5 nice areas: understanding, preventing, diagnosing and treating, quality of life, equitable access. All these are key questions. And nice, and they call it bold recommendations again, not happy recommendations. So they came out with these recommendations, and they're allocating 5 billion euros to do this, which is a big sum of money. So they have these recommendations, and they had this mission-based approach because they wanted to corral or try to get more of the different fragmented approaches across Europe working together. So this was the idea to do this. But for example, on the screening, which was highlighted earlier, then you had a council conclusions on screening, but they left lung cancer, they included lung cancer and prostate cancer in terms of screening, but you call it a stepwise approach, which means there's many steps to get to the starting point. And one can see when they implemented screening guidelines for breast cancer, cervical cancer, and colorectal cancer, this had a huge benefit across the European Union, because this also recommended all countries across the European Union implemented these guidelines or tried to implement these guidelines, and this had a big impact for tackling breast cancer. So these are key questions. So we developed different fact sheets around for each country except for Greece, and the reason for that was we didn't have enough data. Okay. And then I wasn't invited by George also, so maybe he will invite me back. But the core questions are then, what is the infrastructure and tools that should be put in place? What are the molecular tumor boards and expertise? Reimbursement for NGS. So reimbursement for NGS and liquid biopsy. Why is NGS important? Because often the oncologists may do single panel, say they do for a certain test, but then they do a lot of single, which would be better if you do a broad panel testing, which will be more effective. But then if you're looking at that, then we should set up systems now to support these type of technologies now that would help bring in investment both from the private sector and public sector to support that. Then this education and training needs, what needs to be put in place to support broader citizens and patients awareness, but broader public health awareness. So, I mean, we can see from COVID that the public health workers, which are often just focused on vaccines or focused on epidemiological issues, can be another key actor to drive forward more awareness in the broader community. Then a whole issue around governance and the alignment between governance. I mean, yes is yes and no is no in terms of consent. I mean, there shouldn't be a million interpretations of this terminology. The same issue with opt-in or opt-out. These are discussions at the European level regarding European health data space. And then healthcare workforce and data sharing and linking. So there's many plans at the European level. So one can see, okay, yeah, because it was highlighted earlier too that we need to consult with everybody. It's true, you need to consult, but to build consensus. But also you need to implement. We know a lot what can be done, so we should try to implement. And looking at different countries, one can see different countries are falling behind here. You can see, so core for in terms of infrastructure and tools, the European Union is putting a lot of money into that. Then you have all countries, most countries have a comprehensive cancer center that support NGS. They have the equipment there, they have the funding, they have the routine utilization. You can see Croatia was in red there for routine utilization because when they had an earthquake in Croatia, they all went to the basement, and then they found in the basement, they found sequencers that they never knew they had. So that's why. So, but I highlight this because a lot of infrastructure is bought by the hospital managers, but then it's not utilized in a very effective manner or applied in an effective manner. And that's a question also. You can buy all these nice technologies, but the question is to implement what we have. So this is the key. This is the key issue. Then molecular tumor boards is another factor where most countries have them, but also you need broader molecular tumor boards across different countries because now we have more and more understanding of diseases. The expertise are not in each country. So the issue is then what is the framework for that and a methodology around this. So we're working in big EU projects in the area. In terms of reimbursement, all countries highlight reimbursement as a big issue. But reimbursement is a big issue because there's legacy issues. People reimburse surgeons for surgeries, but reimbursing like liquid biopsy or next generation sequencing, they're not so familiar. Insurers are not so familiar with some of these topics, so they don't reimburse. So this is a factor why reimbursement for NGS has become a struggle. Every country recognizes the benefit to have more information, but then how to apply this information. This comes back to the point about the systems, healthcare systems are set up to treat patients rather than diagnose patients, which should be the focus actually to improve quality of life. Then education and training awareness. This is a core issue. Everybody recognizes that we need more pathologists, we need more biostatisticians. We don't need people who are experts in fax machines anymore. We don't need people that are good with stickers that can put coding on different issues. We need more of the right healthcare professionals that can support the different areas. And this really needs a framework at the European level to say, okay, what is the industrial policy that we need to train the healthcare workforce that we can utilize these different technologies more effectively. And this will also attract investment. Then the governance issue. You have different governances and frameworks. So you have ISO accreditation, you have clinical guidelines, you have the internal guidelines, external guidelines, so the regulatory, and then you have the assessments. And you have different, this is available, not available in different countries. So there's no standardization across the countries in Europe. So this is a big issue that there should be standardization across the area. The same with healthcare workforce, France and Germany. And they're always the best, so they said they have everything available, but the rest were more modest and they said they didn't have it available. But there's a big shortage of healthcare workforce across Europe. Also, this is also because different doctors can get higher salaries in different countries, so then there's a lot of migration to other countries. So this is a question, how can we standardize, have a minimum standardized salary to support keeping doctors in the same country, rather than just having wonderful Greek food and weather. So this is an issue. Data sharing and linkage is a similar issue around because you need to correlate between different areas in terms of security guidelines, data sharing, data linking, and controlling bodies, and what is the framework best there to support this. And different countries, again, struggle to put this in place. And the legislation is also causing a lot of problems. So I have a few more slides. I'm getting to the end. So on the data sharing and linkage, again, this is another question around how data is utilized. The biggest driver in terms of an action plan, I would say, focus on data. Because one needs the evidence. Often it's very much overlooked. People focus on prevention, which was highlighted by the professor earlier. But prevention often gives politicians an easy go ahead, because you can say, oh, we just focused on prevention, rather than focusing on how we treat existing patients which are really suffering. And this is the core question. Data infrastructure, again, you have different factors here on cancer registries, or in terms of what is the evidential needs in different countries. And this has caused huge problems across Europe. So then my colleague has developed a key here, a legend, in terms of a funny star, a nice star, a circle, and an X, in terms of linking data from sequence data. And this is important, beyond the funny figures, that we need to link data from different centres to have a better understanding of the diseases. And this is of crucial importance, because without the clinical evidence, without the policy evidence, without the reimbursement evidence, we can't go forward. So the evidence needs to be put in focus. There's a big discussion in the European health data space, but the biggest problem is curating the existing data that we already have, or just forget about the existing data, move on to let's curate all new data that we get, which would be a starting point. And Europe could put money into supporting that. And then again, how do we give these results to different centres, and then how do we share genomic data across the European Union? And this goes back into this opt-in or opt-out issue. I mean, the European health data space is about opting out. We want to put forward opt-out. But Germany, Netherlands, France, which I spend most of my time in politics discussing this, they're focusing on opt-in. And this is important, for example, on organ transplantation, for giving the organ if you die. It's opt-in Germany, but it's opt-out in Austria. Of course, then people don't know. They have to opt in, which decreases the amount of data that is shared. And this needs to be a strong point from the patients that are saying we have trust in our own public healthcare system, that we trust the doctors. I mean, obviously, if somebody steals the data, then there's a criminal issue. So we have, I won't skip some slides. So we have a fun paper. We have 4 academic publications coming out. We have 1 in Nature Medicine coming out in the upcoming weeks around this. And some of the key findings: yes, we need more work in terms of infrastructure. Prevention is key. Treatment is key, and genomic sharing. But you can have all these frameworks in place. But then again, it comes down to the doctors in each country. I mean, you have this for colorectal cancer, and you can see how resources are allocated in each country. And irrespective of what the guidelines said, doctors then operate in different ways, or healthcare systems operate in different ways, which creates this focus on inpatient care, or outpatient care, or primary care, or A&E. So there's many different tools in the area to tackle cancer, but with George's help, maybe we can find the right tools to do this. And the issue of personalized medicine is really, do we agree that personalized medicine will help us have a better clarity of what is the disease and how we treat the disease? Or is Mario the same Mario as he was 30 years ago? He can still jump up and jump around and jump up. But the question is whether, if we have more clarity on understanding of the disease, can we move forward to treat patients better? There's a lot of clarity in the science now. There's clarity in innovation, but there's lack of clarity in terms of how we implement it. And tackling this implementation gap is a key question that Europe will struggle with. Mario is there, happy to run, like George is there, happy to run, but the issue is, how can we help George get more clarity so that he can communicate to the politicians more effectively? Thank you.
Thank you so much.